It was
Hello. Hello. So hi, everyone online. Can you hear me okay? Yes, Helen's saying yes. Wonderful. I'm just going to wait for one more minute because I know people often join us bang on 12:30, and there are some people still coming into the room. So just be patient with me and just wait for anyone else. Actually automatically zooms out, so it goes in and out. Yeah. Can I also confirm that you can see the slides on the screen? Yep, great. Thank you, Helen.
I see. I've got Emma there. She's our GP healthcare specialist.
Oh, how fantastic.
Dr. Thomas, yeah, she's good. Might be a few other names I recognise, but I recognise a few names.
Hello, come in. Hi. Hi, hi. Hello. Cool. Sure, yes.
That
100%.
because I did things quick.
Really think we secrets that we start to unpack as we. Nice to see you again, you.
它有这么多粉丝，
We've now got a bit of a full house here, so I'm just going to zoom out so you can have a look and feel like you're part of the whole event. You're online. I think we'll get started. So welcome everybody. Thank you so much for being here. We really appreciate you coming to NTI or joining us online. I understand that time is precious these days. So it's really wonderful that we can get together for these types of events. My name's Nadine Levy. I'm the Head of Health and Social Wellbeing here at the Nantian Institute. And I have the honour of hosting our guest speaker here today as part of the NTI Conversations series. Dr. Philip Spenley is now a friend of NTI, and he's someone who has done a lot of investigation and contemplation on this topic, a topic that we don't really talk about enough and explore enough. And I know a lot of people are very interested in some of his insights, so I'm delighted that he can be here. So I'd first like to acknowledge that we are on Dharawal country, and I would like to pay my respects to elders past, present and emerging. And I'd also like to extend my respect to any Aboriginal or Torres Strait Islander peoples here today, either on the screen or in the room. So let me introduce Dr. Philip Spenley. He originally trained as a pharmacist, and I understand that he's still working in pharmacy at the Milton Hospital. He has a background in palliative care as well, having worked at the Port Kembla Hospital as the chief pharmacist in palliative care for 5 years. He also has a PhD in microbiology from the University of Birmingham. He's worked in technical services and direct patient aspects of hospital, and he's been very interested in this topic since he was asked by a colleague to do a talk on it. He didn't know much about it before he started to prepare the talk, but once he prepared the talk and gave it, he was hooked. And so we're here to hear from Philip about what he found out and what this might mean either for patient delivery or the way we relate to others who are in the dying process. So over to you.
Okay, thank you. As you can see from the opening slide, it's the patient's final journey. So this was originally aimed at obviously people working with terminal patients or end of life care situation. And the idea is to actually make it a little bit more comfortable for the patient and also for the patient's relatives and for staff alike, because it's obviously a traumatic experience for everybody. And as Nadine says, when I first looked into this, I thought this is, shall we say, a load of rubbish. But the more I read, the more I was convinced. My job isn't to convince you. My job is to give you information, which you can then take away to convince yourselves if you want to. If anyone's interested, I've got copies of all the references I cite here, 75 of them, if you would see, and the ones which are indicated in red are open access. You can obtain those for at no charge off the internet. Right here, so let's dive in. So what is it? Near-death experiences are intensely vivid and often very life-transforming events for those who experience them. A general idea, but general concept is that they occur under conditions of no brain activity, either deep general anesthetics, cardiac arrest, or other areas where there's no functional or detectable brain action. So it's not a brain event, it's another event. And according to the prevailing views in neuroscience, this shouldn't happen. But unfortunately, it does, which is good because there's nothing like rocking the boat. Near-death experience was originally coined by Raymond in 1975. I can recommend reading his book. I've got a copy at home. If you can get the copies, or most of the books you can get through interlibrary loans. He's in his book, Life After Life. But accounts have been going back for a long way. Oral history is going back into Sumerian times and beyond that. Even in the Western research, it goes back to well beyond the 19th century. So it's not a new thing. It's becoming more, the people are getting more interested nowadays because there's more information. But the concept of NDEs is going back a long way. Right, so what's happening with more and more people are reporting NDEs. And I suspect that's for two reasons. One, because it's becoming less taboo to talk about these things. And secondly, because some out of hospital and hospital survival from cardiac arrest is getting much better. The days of the ambulance service being scoop and run have long gone. All the ambulance crews are trained to ACLS and ATLS capability. They can all provide definitive resuscitation en route. So patients are surviving longer. They're surviving severe duration cardiac arrest, which would previously kill them. So we've got a larger cohort of patients who have had the opportunity to have an NDE, who can then report back to us and say, well, yes, I had an NDE, and this is what happened. So, and also, because there's more information out there, more people are a bit more flexible in their understanding of these things. People are more willing to take a more, shall we say, spiritual rather than systematic viewpoint. The taboo for near-death experiences or talking about death in period is being replaced. So there's a lot more openness, and the more openness, there's more talking. So and those who have experienced an NDE nowadays they don't feel as if they have to hide it under the covers a bit. They can actually be a bit more open and say, look, this is what I've had, and so have other people. Right, so what usually happens? Well, mostly for 95% of all NDEs, the defining factors seem to be quite pleasant. There are a very small number, I think it's 3%, who have distressing NDEs. But there's a lot of evidence, if you read the papers, that these actually might be what we call ICU psychosis or ICU syndrome. So it's not a true NDE. But even if you discount the fact that it may be a true NDE, but unpleasant NDE, the majority of NDE patients have a pleasant experience. So people have a pleasant time, tend to talk about it. So one of the first things that people mention is that the experience is so profound that they're unable to put it into words. So it also depends on the patient's educational background. Obviously, with a larger vocabulary, they can put it into words to a better extent. But having said that, everyone seems to have the same experience. And it seems to be a central core experience. There are central core experiences which are unique to NDEs and which are prevalent through different religiosities, different educational backgrounds, different social backgrounds. It's all the same. Everyone seems to be reporting the same thing. So what are they? What are the basic core experiences? Pardon me. Comfortable and free of pain. Obviously, this is important for bowel care patients, but it's also interesting that suggests that there's no afferent input. So the experience is not associated with brain function. Sensation of leaving the body, that's reasonably common. We'll cover that in a bit, but sometimes they can actually see the physical body while floating above it, while people are doing CPR. That's interesting because they give you extra details. Find mind functioning more clearly and more rapidly. I'll cover that later on, but yes, that seems to be the case. They have a better perception of what's going on. Two things: sensation of being drawn in a tunnel or darkness, and a brilliant light at the end of the tunnel. Now, you think back, you've all heard the story, the light at the end of the tunnel. Is this something which we're harking back to in sort of a collective memory? Have we experienced, have we a collective memory of NDEs in the past? And this may be the reason behind this phrase. I don't know, but it's something to think about. Sense of having peace, well-being, absolute unconditional love, or as others have put it, a return to the collective or the return to the family. And this also comes into the concept of the collective consciousness, which we'll cover later on. Sense of having access to unlimited knowledge, a life review, where you actually look at important events and how your behaviours affected the behaviours of others and how others have viewed your actions towards them. A preview of future events. Unfortunately, I haven't had there's no evidence of people having NDEs being given the future lottery ticket numbers, but you never know. The data is being still acquired. Encounters with deceased loved ones or other beings which may be identified as religious figures or just other beings. And some patients report having recurrent encounters with other entities, not necessarily human, which is interesting. So that's a look at them. What's the statistics? About 70% of those who nearly die report an NDE. Now, we think that this is a massive underreporting because people don't talk about death and people don't want to know about people dying. So it's something which in the West people don't talk about. So it's probable that could be at least 50%, maybe more. So it's, if you're working at 70% is a very, very low figure. So it's very likely that a lot of people have NDEs and they just don't feel comfortable reporting it, and they won't. Genuine events. Well, Jeff Long did he runs the NTERF, and they've so far got 3,700 searchable accounts. So everyone's welcome to look nderf.org. It's open access, so you can search the database, you can look at their correlations, and you can make up your own decisions. But certainly from their viewpoint, these are real events. They're real events to the individual, and that may be all that matters. It's the individual's event, so it's real to them. So what are the events? So first of all, we've got the lucid organized experiences. The patients allegedly so compromised, they're clinically dead. They have no detectable brain function. Yet the majority of people having NDEs report highly lucid events. They're logically structured, they're clear, and their level of consciousness was greater than normal. Remember the previous slide or two? Their brain was working faster and more efficiently. There we go. Level of consciousness is greater than normal, 74%. That's not an insignificant number. That's a significant number. Verifiable event recollection. This is where it gets fun because many EDs occur as a result of in-hospital cardiac arrest because of any event. Generally accepted that CNS activity stops after 10 to 20 seconds. So the brain becomes isoelectric. No electrical activity at all, no synaptic activity. Nevertheless, such patients report clear, detailed, lucid, and verifiable recollections of the resuscitation. These are patients who've had no previous medical experience or medical knowledge, giving you a blow-by-blow account of what's going on, what was being used, and how it happened. That doesn't happen. It's not supposed to happen, but it does happen. And it's not one or two cases, it's lots of cases. And this ties in with the out-of-body experience because many of them say that they can actually see their resus going on from a distant position above and to the side of where they were. They can actually watch themselves having CPR and all the other bits and pieces done to them. And are they accurately accurately and comprehensively describing their resus? Well, let's go and check on the resus notes, post-event notes. Yes, they are. Yes, they are able to give us a very accurate and very comprehensive details of their resuscitation. That shouldn't happen, but it does. And for many people, this out of body seeing yourself thing is the most memorable aspect of NDEs because they know what the hell's going on. And this is the bit which made patients, sort of accustomed patients to them, think, well, is this the real me? And for patients who've had NDEs, they tend to have a very much more spiritual view of life. They're not so systems based, and they're spiritually based. And that book is worth reading. Susan J. Blackmore Seeing Myself. I've read it. It's very good indeed. And they've got plenty of references, so you can go and read a bit more. Observation of events from afar. Well, Michael Sabon did this. He published a book on Recollections of Death and Medical Investigation, which I've read as well, which is also very good. The patients who he was looking at patients who had survived with an NDE event, and patients who were resuscitated and then did not have NDE experiences are able to provide any accurate account of proceedings, as you'd be expected. Patients who did get resuscitated did have an NDE, gave a very accurate. There's a big difference. There's a big difference between giving an accurate recollection of events and no recollection of events. And the ones who didn't, and the ones who did, which is interesting. And the events from afar bit is interesting because sometimes the patients can detect or report on events happening outside their room or in the corridor. So there's no current way we can explain that. Obviously, it's only a small subset, but there is nevertheless a subset of patients who are seeing events far from the physical body and well beyond any conventional sensory awareness. Interesting. And the thing to notice there is 97.6% of reports have no fabrication or unreal content. That's a very high percentage of reports. Okay. Of course, traditional medicine, what's they're having psychosis. Well, yeah, okay. And we do release transmitters in the brain when the brain starts shutting down, called DMT. But the effects of DMT psychosis are quite characteristic. And when patients have an NDE, there are no detectable changes. PET imaging, functional MRI, EEG, no detectable changes. EEG flatline. There's nothing going on. The lights are off and there's no one at home, yet something's happening. So it's interesting what's going on. And as I said, these out-of-body events are associated with the absence of detectable brain activity. Whereas if you give them psychedelics, you can see massive brain activity. So it's using it's a psychedelic thing. Yeah, it doesn't hold water, that doesn't. Only looking at this idea of expanding the patient's consciousness. This looks at the patients who are detecting things outside their room. Well, if they're detecting things outside their immediate environment, what sensory systems are they using? I mean, even in patients in drug or nocturne-induced states, they're hallucinations, but hallucinations aren't detectable events occurring outside. Detectable events occurring outside which can be reported and confirmed. So this brings up the concept of long local consciousness, which is interesting because that's a whole different ball game. That's exciting stuff. This is another one. This is another good book to read because I've read that one too. It's looking at the patients who are functionally blind from birth, and some of them experience NDEs, and some of them report quite good visual events. They can see, yet they couldn't see from birth. And there's only a few patients, I think I had 9 patients reported such events. Even so, it's quite a few from patients who were blind. And patients with defective vision were also reporting that their vision had improved. Patients who didn't have defective visions find that their visual clarity was actually supernormal, especially in terms of color brilliance. And not only color brilliance, but also in visual range. Ability to see into the infrared and UV regions. The ability to have zoom vision and seeing everywhere simultaneously. So if you replace vision with sensation, you're now sensing everything visually everywhere. Vision's not part of it anymore. It's an external sensation process. So we don't understand what's going on here. It doesn't correlate with any kind of understanding of brain function. So obviously there's something happening there. People have reported these things happening there. Numerous people have reported these things happening there. Something's happening there which you're not aware of. And you just can't ignore the data. NDEs occurring under GA. That's interesting because under GA, there's no brain function. The ability to form memories is obliterated, which is the reason why we use general anesthetics. So patients can have unpleasant procedures, they don't remember them. Interestingly enough, patients having NTEs under a GA have a more lucid experience than the ones who just have NDE as a result of cardiac arrest or other events. So it looks almost as if having a general anesthetic pre-primes your consciousness, not the brain, the consciousness, to have a more clear experience. The analogy would be getting your vision adapted in a darkened room. When you switch the lights off, you can't see too much, but if after a while your vision, you can start to see things. Is this what we're seeing happening here? I don't know, but it seems to be a comparable analogy. It seems reasonable. I might be wrong, but it seems reasonable. Very high instance of respondents to supernormal vision, higher degree of consciousness alertness than normal, and a better, as I said, better results than the patients who had an NDE not under GA. Now, as I said, the sample size is small and the numbers were statistically different, but nevertheless, it's interesting. So are we seeing anesthesia acting to pre-prime the system? I don't know, but it would seem that maybe is an appropriate comment. Life review phenomenon. Not all patients have an NDE have it, but some of them do. And reviews seem to be from a third person perspective, as if you're on the outside looking in, and you're seeing what others are thinking and feeling during interactions. Now, none of these reviews seem to have any unrealistic or fictitious content, and quite a few of them seem to date back quite a long way into childhood, because patients who've had these reviews, they can say that they were recurring events from their past lives, which could be confirmed by relatives. They'd forgotten they were going on, but apparently the life review phenomenon remembers these things. So how, we don't know. And also questions how we think memory works, because we think there's a biochemical basis to memory, but this suggests that there may not be a biochemical, there might be something else. There's a lot of interesting work in this area. Deceased loved ones. Well, that's quite a core aspect of NDE experiences. A lot of patients experience encounters with people, loved ones, relatives, mum and dad, that they knew in the past. There's some interesting occasions that patients have had encounters with people they thought were still alive, but in fact were recently deceased. So it seems the encounters are always with people who are consistently dead, not with people who are alive, which is something to bear in mind. So if you bump into somebody who you thought was dead, was still alive, probably not. That's interesting. Children. Well, what you'd expect, that children aren't very good at fabricating information. They can fabricate information, but the evidence for the very long, who haven't got religious, cultural understandings or understanding of death as such, there would be a very useful sample set. And yes, for the under 5 subset, their experiences seem statistically similar to adults, even in pre-linguistic children. So it's not based on adulthood or sophistication. It happens to the young as well as the old, or the older. Cross-cultural observations, NDEs need to be pretty much the same, irrespective of which culture they come from. Western countries, non-Western countries, Christianity, other religions, the reportage is very much the same, irrespective of background. So it appears that the experience is not substantially modified by pre-existing cultural differences. So that's interesting. So that, once again, seems to indicate it's a true event rather than one which is culturally modified. After effects. Okay, so you've sort of died and you've sort of come back and you've had your NDE. Great. So do these patients experience life changes? Oh, yes, they do. Over 50% have major life changes, and a further 24% have moderate changes. 20% experience no life changes, and I think that number's out there to understand that. And this looks at a group assessment 2 and 8 years post NDE. Worth bearing in mind that the patients were asked 8 years after their NDEs can still recall the NDE. So it's not something they dreamt about of fresh air. They obviously, it's an experienced thing, and it's an experience that's been burned into their consciousness. depending what you consider consciousness. And this may appear from people who've known them in the past. They said that people have changed; they've become different people, and this, the effects might take some time, years to become fully manifest. Yet the consistency and durability of such effects seems to be closely tied with the NDE experiences. The people who had an NDE think that their experiences are both real and meaningful for them, and people who've had a positive NDE are more inclined to talk about it than people who haven't had an NDE. So 1,112 patients, a decent sample size. 95.6% regarded their experience as definitely real. That is a very high percentage. If you look at stats for all kinds of other biological systems, that's ridiculously high. Only 4% regarding their experiences as probably real. Less than 4% regarding their experiences probably definitely not real. And you wonder how many of those 4.4% are saying that because it is so different to their normal life view that they just can't process the information. And we're not talking about the general public, we're talking about physicians, nursing staff, other professionals. It's interesting stuff. From the palliative care viewpoint, NDEs and the fear of dying are closely entwined. And obviously, the feeling of dying is a major problem in the terminally ill because people don't know. They are scared of dying. Thanatophobia is fear of dying. Obviously, there's psychopathology and you get psychosomatic disorders, and all of them increase the anxiety levels in the patient. So when you've got an anxious patient, the perception of pain increases. So it's if we can reduce the fear of dying, we can reduce our anxiety, we can maximize the analgesic window, we can improve their quality of life up to the point when they're not with us anymore. So reducing the fear of dying by whatever means is a very important thing. And if NDE experiences can help that, I'm all for it. And this is where it becomes interesting because the loss of the fear of dying seems to be a very central effect of most people having NDEs. Ray Moody's original book mentioned that there's almost a complete loss of the fear of death. Some patients saying, oh, they regard death as now just a normal bodily, normal function. It's just moving from this life to the next life. And there have been so many studies, there have been a lot of studies after that, and quite a few on my site here, showing that this loss of fear of death ranges from 80% to 100%, with the modal range of being 95%. So having an NDE is good for you. So it doesn't make you decide that dying isn't what it was. Dying is now something which is not to be afraid of, and it's just a normal process. Although it's a one-way process as far as we're there. So could it be said that NDEs are acting as a protection factor? Bearing in mind that 29% who had come close to death without the experience of NDE had no decrease in fear of death. They had no changes in their fear of death. Michael Sabum said 82% of NDE experience subjects have a reduced to abolished fear of death versus 2% of non-NDE subjects. So that's a big difference. So having an NDE makes you less anxious about death, which is good. Because, like it or not, we all go there one day. Not quite saying death is a positive experience. So that's not, it's not suggesting that, but it's loss of the fear of death is very, very multidimensional, and there's so little published data. Having said that, there is, if you're prepared to dig around, you can find a lot of it, well, adequate information. And the positive emotional content of most NDEs correlates with perceived reduction in death threat. So then perceiving death as a positive. I'm not saying it, we're all dashing out there to do the deed, as it were, but it's a positive rather than negative experience. So it's just another part of life. And it's not a negative part of life. It's just something, you're just changing from this life to another life. And also it's Bruce Vaisden's assertions that death, so while the death process is more than just a cognitive and affective experience, there's other things going on. And general medicine is now accepting that there's a transcendental element, which may be equally, if not more important, in part of the dying process. Now, this goes back to the management of death seen in the pre-Christian era, because the death was very much more ritualized, and there was a lot more concern, and the person dying was a lot more involved in their dying process, which is fair enough because it's after all everyone's dying. So, similarly, it's corny, but meeting and greeting the deceased, that seems to improve, correlates well with this increased death acceptance, because the people who had seen relatives or people they know on the other side are more inclined to want to go back that way in due course and re-meet them to catch up where they left off, as it were. So it increases your acceptance of death, or acceptance of no longer existing on this mortal plane, as it were. And obviously, the other, as we mentioned, the first two of these slides, a sense of peace, tranquility, and painlessness, and joy, or possibly loving, and the recurrence and the return to the collective. The collective concept is, there have been a few papers on that, and that's sort of interesting too. So, end-of-life experiences and palliative care, and they get the gritty. So the problem is, medicine at the moment, even now, is very much systems medicine. We treat it as objective medicine. Near-death experiences are subjective, so it doesn't make the mechanistic model that people are taught in medical school. They are just, when the brain dies, consciousness along with everything else dies with it, and that's it. End of story. Goodbye. Now we know that consciousness is less processing isn't in the brain anymore. We know that there's a lot of spinal systems processing, and there's also a lot of processing acting with the gut, because you've got the enteric nervous system, which is also involved in information processing. So it's not just the brain. The brain is just one part of it. There's a lot going on downstairs, a lot of pre-processing, certainly. And yes, a lot, as it's very well regarded viewpoint, that a lot of these phenomena have been ignored. It's just because they don't fit the current dogma. People have just thought that, we can't accept that. But there is now a gradually and also increasing replacement of objectivity with a more relativistic relative aspect, where we're looking at value-laden events, and we're just thinking that maybe the Western cultural assumptions aren't quite correct, or they might need modification, which is quite good. So we're now looking at the subjective experiences of the patients who are dying, rather than ignoring it and say, it's just it's just what normal process is. It isn't. Everyone's departure may be different. Peter Fenwick's, he's done a lot with the Camden Palcare team. He's very interested in this area. He's published a lot of information, so I recommend his books. They're fantastic. He thinks that these end-of-life events are intrinsic transitional part of the dying process. Many working in Palcare, you know that patients often have sort of bedside death experiences. They have these sort of dreams of departure, and that might be as a preview of the end of life experience. So it's an interesting process, and these events seem to be more concerned with letting go of the physical world in a controlled fashion and preparing what's going to happen next. So that's just, it's a transition, not an end. We're just moving from this existence to another existence. And it's an idea which is held irrespective of religious beliefs or whatever. And just in practice, that's the Journal of the Royal College of Nursing. So that's a legitimate journal. And it's been reported that many patients are having deathbed visions, usually of deceased relatives. Frequently it is the patients take the most emotional contact with. And it would appear that the purpose of these visions is to assist the patient navigate the dying process, which is reasonable. They almost always provide a comforting experience, and maybe the ability to provide a spiritual experience for death. Who knows? This is something else which is, and it doesn't happen, except it does. There have been consistent reports over the years by professional carers of seeing something leaving the body, usually for the mouth, head, or chest. So it has happened. And you don't believe me, there's lots of papers there which you're welcome to look at. And if you look at some of the books, the Sabom's book, that mentions this as well. It actually really is a real event. Not everyone seems to see a vision. It seems to be associated to those with a strong emotional bond with the deceased, so relatives. whereas distant relatives may not see it, but it does happen and people have reported it. So it's something interesting, and it dates back quite a long while. 1926, Deathbed Visions with Sir William Barrett. He described this sort of thing happening. Distances of something very visible leaving the body at the time of death, a vision of this. And there have the reports of other phenomena, effects on photogrammetric glasses worn by the deceased. That's been well reported, and it's interesting. What's going on? I don't know. I have no idea, but it's interesting. So as soon as I don't know, I want to know. Deathbed coincidences, once again. It's the patient's relatives or friends who have no idea that the patient's imminently dying. Could be miles away, could be different continents. Yet they know that the patient's dying. They may not even know they're ill, but they know the patient's dying because the patient appears to visit them transiently, and the purpose of that visit is to let them know that cheerio. Yeah, it's it's my turn now. It's your turn next. Yes, this is not fantasy. This is well reported. Hallucinations. Here we go back to the DMT thing. So they're saying that, oh, it's all drug-induced or neurochemical hallucinations. No, typical drug-induced hallucinations. You've got the new moving patterns or insects on wallpaper or animals or children running in and out of the room. These visions can be controlled by pharmacotherapy. They're not particularly frightening, but they can be managed by pharmacotherapy adjustments. We normally give them sedatives like midazolam. And that seems to help a bit. Not always, but sometimes. However, they're not hallucinations. The true EOL end-of-life visions are very, very comforting. They don't cause any anxiety. They hold some profound meaning to the patient, and they appear on daydreams. They're not truly daydreams. They're more waking dreams, different from normal dreams. And there seems to be associated with changes in the patient's behaviour. They become more relaxed, and because they become more relaxed, their relatives become more relaxed, and everyone's doing well. So it's a win-win all the way around. So that's good stuff. So what's the significance? Once again, systems medicine. The majority of discussion relating to this end of phenomena has been centered on the subject providing evidence. We have to have evidence to life after death, but it's difficult to do that. But if you look at the frequency and occurrence of these events and talk to the palliative care staff who've experienced these things, it's interesting. People have seen these things. They've seen these events. And so we can forget about the life after death thing. We can concentrate on what's going on. Systems medicine, we're still taught that death is the enemy. Death is a failure of the system. But death is part of the living and dying cycle. It's normal life cycle. We simply need to reassure the patients that they're not, while the patient's having a very personal, and they are very real experiences, and they happen to many people, and most of them will find them comforting. The patients aren't having hallucinations and having a real event, which they find comforting. I think that's good, because if the patient's finding beneficial, that's good for everybody, especially the patient. Encourage them to talk. So we encourage discussion with patients who may have had these end-of-life experiences. Unfortunately, because of social backgrounds and the way the systems work, many reluctant to discuss this because of ridicule, embarrassment, there's Gran's lost her marble sort of thing, yeah. And there's also the real fear of upsetting already distressed relatives who do not want to have something going on. And, the patient wants to appear completely deranged. And obviously, in many hospital wards, there's no privacy. So all these factors mean that reporting in this area is going to be a bit on the sparse side. But what we can do is we can make it often open to the patient to be willing to listen. And of course, if we make it clear to the patient we are willing to listen to them in a non-judgmental manner, they might be willing to tell us part of the story for testing the waters. And if they get a positive feedback from us, they might give us a bit more information. And so by listening to the patient and interacting with the patient in a way that the patient finds comforting and reassuring, that you think that they're not having hallucinations, it's a real event, they'll tell you more. And the more you learn, the more they tell you, the more you learn. See, the problem is, in the West, we don't like talking about death. There's this general social taboo on talking, even thinking about death. It's something you don't talk about at breakfast time, isn't it? I mean, it's, let's have a quick chat about dying next week. I'm ideal for that. No, we don't do that. And from certainly in the Western attitude, we are very happy with the idea that once our physiology stops working, it's death of the soul, annihilation of self. There we are. That's it. Patients die. End of story. Switch off lights. That's it. But apparently, it's not. It's the evidence is there. And the reason behind this is Solomon and et al. Came up with something called they've got the terror management team, which was quite good, because TNT is how we create barriers to talking about things we don't like, unwritten rules or taboos, mainly relating to suppression of even the mention of undesirable events. Like people don't like talking about death or nuclear war or things. They just don't talk about it because you don't talk about that sort of thing. And that's an example of this. People don't talk about it because they don't feel comfortable. But perhaps it's about time we started feeling comfortable because it's important stuff. Oops, sorry, wrong way. Okay, so how can we use this information? NDE and EOL experiences provide significant reduction of what occasionally is the existential dread for the patient and for the relatives. What can we do for that? We can actually use it to improve the patient's needs. We can improve their psychological needs. It's very good at reducing their analgesic demands because they're less stressed. If we're talking to them about the patient is talking to you about these things, and you're openly talking to them and saying, yes, what you're seeing is real, let's talk about it. They're going to feel much more comfortable. And because they're more comfortable, they're more relaxed. And because they're more relaxed, their analgesic demand decreases. So it's better for everybody. And of course, then you get questions of what might happen when I die? What happens after I die? Well, yeah. So what should we be doing? Well, I think we should have a greater understanding for all healthcare personnel of the spirituality of the events. So we need to have, by extension, additional community engagement with carers to discuss both end of life and ND phenomena. We need to discuss this because patients very well might be having it. And we just can't ignore it. I know there's evidence is subjective evidence, but it's very appropriate to at least offer some direction towards the NDE discussion, because it is clearly of real patient and carer benefit. It's improving the quality of the patients to what's left of their life. So it's important. I'd say that's an important area. So life after life concept. Well, we're at 40. Okay, should be okay. Post-death experience. So lots of non-European religions have always had this life after life concept. Raymond Moody's book, obviously, we went into that, and the Netflix documentary "Surviving Death," which I did. That's worth watching. It's an interesting documentary. It's a bit superficial, but hey, it's better than nothing. So obviously Bruce Grayson, he's a bit more authority in this area, and it's quite likely that people may have read his books. They may be expecting us to be as well informed or very well informed as to what happens when patients die, especially around the peri-death environment and ND situation. We should be involved. So consciousness, do we continue after death? I don't know, but the evidence seems to suggest the answer is yes. And understanding of how the mind actually works is incomplete. So that brings into interesting areas like, does that consciousness continue? Maybe, we don't know. But the evidence that ND experiences suggests that it does. And then you've got the non-local consciousness thing, so how the patients can see things outside the room. Something's going on. It's been reported. It could be confirmed that the thing is the real thing. So yes, maybe we're actually seeing things happening outside the body. OBs, non-local consciousness, there's a lot of experiments on this. There have been a lot of papers, lots of books as well, and the very nature of these reported OBs, where one can bodies move from afar, would seem to be the definition of at least a non-local component. If you're seeing yourself from somewhere else, where's your consciousness? It's not on the table, it's somewhere else. Local consciousness, there's a lot of things. I'll skip these quickly, so a bit short on time. But there's a lot of interest. There's the hard problem. The hard problem, well, obviously, from the easy problem is using the brain as a better computer, but the hard problem is it's actually a sense of self, and we're thinking maybe that the brain may act as more a sophisticated transceiver than just a single processor. It may be a network system. quantum consciousness. This is an exciting area. And Hamroff and Penrose, Conscious and Events as Orchestrated Space-Time Selections. Very good paper that I've got a copy of it in one sort of bit. But we're looking now at the possibility of consciousness as being a quantum event. It's realization or collapse of the wave function to give realization of consciousness. This is a bit exotic. That's interesting though. And it comes quantum consciousness is an area where there's a lot of research going on. And the ideas are entirely in accordance with current quantum theory. There's nothing unusual. This is actually wave function collapse is fully accepted theory. It's been fully accepted since the 1970s. So it could be the thing. And are we looking at the boundary between quantum and classical physics? Yeah. So it's saying possibly that there's people saying that the information which made consciousness may exist at the sub-Planck scale level. A lot of papers on this. OR from Penrose. This could be happening at the microtubule level. This is a big area. One slide. This has got so many papers behind it. You really need to go look into microtubules. It's fantastic stuff. It's happened. It's computation at cellular level. Amazing. But yeah, that's possibly one reason. Cribbin-Bohm hypothesis. Interesting. Very, very out there, but interesting read. So I recommend that. Then Shelley Joy, she also published on the electromagnetic plane. This ties in with the electric universe idea that we are all part of a electric field universe. I don't necessarily buy into that, but I'm prepared to accept that basis on the basis that we do know that external electromagnetic fields can influence the brain. And there's a few concepts that may be your final moment of eternal. Ellman and Casper both wrote papers on this, but this is getting a bit fringe, so we'll just skip that. But then again, if you want to have a look at I've got these references in the pile there. Okay, so quick skim through the people who are very, very important contributors. Obviously, you've got, not Bimbo. You've got Bruce Grayson. He's published a lot in this area. He's the big name in consciousness research. He's published a lot of books, and most of his books are highly readable. Dr. Lovell, he's a cardiologist from Holland. He published the original article in the Lancet looking at NDEs in post-cardiac arrest survivors. He's also published a lot. And he's also a major contributor to online discussion forum, which is quite good. Pete Fennick, he's obviously mainly concerned with palliative, but he looks at this from a very much a palliative viewpoint. As you can see, he works in quite a few stations in Broadmoor. I have worked at Broadmoor. It's the most secure place I've ever worked. It used to be called the Criminal Lunatic Asylum. Its security there is like makes Fort Knox look like amateur. I tell you, it's an exciting place. And obviously, Pete's published quite a bit. Stuart Hamoff, he's an anesthetist, but he's quite interested in the tubulin idea and quantum consciousness. He's also a great supporter of the electric brain theory, well, the electric universe theory. He's published a bit, and I think that's it, thanks. So, Spice isn't the final frontier, but hey, no, it's dying.
Please join me in thanking Philip.
Sure.
Philip.
I'm a bit mindful I have to skip to the last ones, but if anyone wants a copy of the PowerPoint, just give me. I've got my business card here, so just grab one, send me an email, I can figure it.
Okay, I'm going to try and stop sharing somehow. Maybe not. Could you do it from your screen?
I know, yeah, I shall stop sharing.
Great. So I've invited people online to pop any questions in the chat. We've got 10 minutes. So I might take a couple of questions from online and then a couple of questions from the room as well. I might invite some people to talk in a moment. Let me just get myself sorted out here, chat. Okay, so we actually do have one question already from someone called Angela, who's in the chat. Angela, I don't know where you are exactly, but she asks two questions, and I might just choose one of them for now. And the question is, how are NDEs triggered? Is there a pattern to when NDEs happen to people?
There seems to be no real, there's no real specific precursor for generating an NDE. I think the requirement is the patients have their brain effectively stops working. That could be the triggering process. But since, as far as systems medicine is concerned, if your brain stops working, you can't create memories or have any thought processes. We don't know. And also, it's do all patients have NDEs, or do they have NDEs, but they choose not to report them? They choose not, because obviously it still isn't. It's not mainstream, so there's obviously a little bit of possibility of ridicule. So patients are a bit reluctant to say that they've had an NDE, especially if they're working in an environment where people might question their sanity.
Yeah, sure. Okay, thank you. The next question comes from Melissa Lyon, who asks, any reports on how long NDEs last?
I think the record was from a patient who reported experiencing NDE for 5 years. So that indicates a substantial time dilation, and they were successfully resuscitated. So obviously they weren't dead for 5 years, but the experience of the NDE seemed to stretch for 5 years. So it's interesting. So that obviously time, the perception of time and space in the NDE environment is different to ours.
Fascinating.
That's a single event. So obviously it could be a major outlier, but quite a few of them seem to experience these for what they perceive as tens of minutes or possibly hours, despite the fact they're being resuscitated within 3 to 4 minutes.
Wow. Okay. So also Jonathan Page, who's on the screen. Hi, Jonathan. Has said that he had an NDE 2 years ago. If you want to unmute Jonathan and say something, you're very welcome.
Yes. Well, thank you, Philip. I just thought I would say, because viewing an NDE from one's own perspective as opposed to reading about it or hearing about it. And I'm also from the perspective, I've been an oncologist and palliative care physician for 40 years, a Buddhist. I had a previous relationship with the nun Tien. But I had a cardiac arrest whilst riding a bicycle 2 years ago, and was basically dead on the road for a while. And then a passerby knew a bit about CPR. And I would just say one thing, there's a lot of subtlety, a lot of detail. It's profound. You're never the same again. And I was observing the like the resuscitation with interest from a perspective like outside the body and above. And then as soon as I could tell that it was becoming successful and I was going to return to the body. And as you probably are aware, a lot of people don't want to return. That's quite common. I had that. I had a profound feeling of reluctance and disappointment, and returned to my body, like returning to a dead body. And I've got to say, that's 2 years ago, and I still have that sense that I'd rather not be here quite often. I mean, I've learned to be here, like in the living world, but I think a lot of it's confused by, as you were talking, the inability to talk to anybody about these matters. You know, and I mean, I talk to people who are dying. I talk to relatives who are grieving, and I've been doing that for a long time. And there is a lot of reluctance beyond people, like right in the middle, having a first-person experience or whatever. They may talk for a while. So that's been an issue. So I just thought I would put that in there, that it is a real event, and it does have it has an impact. And you adjust, but never completely.
Well, thank you for that. It's nice to have a patient who's actually confirms what happens. How long did you perceive your NDE to last?
Well, you're in a well, from my perspective, I was in a timeless state. Like I wasn't aware of time passing, but I would think it probably something like 4 or 5 minutes. It seemed much longer, but it just in terms of how long I was on the road, and then the car, and just all the details. I mean, I was unconscious because I had it on the bike doing a certain speed, and I went headfirst into the road. So I had brain injury, and I was unconscious for quite a while. But I remember later, like I remembered the appearance of my rescuer. because he disappeared. I didn't see him for a long time. Took a long time to track him down, but I was able to pick him out of a crowd later.
Interesting. Thank you.
So 5 minutes, 4 or 5 minutes.
That seems to confirm what other people have said when they've had NDEs. If you look at the published data, that's pretty much yours is a textbook example of an NDE. So
Yeah.
yep. And especially the thing that the patients who have NDEs have a reluctance to go back to the real world. They don't want to come back here because they're quite happy where they were. Although having said that, the incidence of suicide in post-NDE survivors is no different to the general population. So having an NDE doesn't make you more prone to suicide. So although many people may want to go back to that area, they still feel the need to complete their normal lifespan here. So that's another interesting thing as well, because there's a survey done with this looking at suicidality, and it's no difference. It's statistically no different to that of general population. So yeah. So although you might be
I agree. I mean, I don't feel suicidal, and I mean, being a doctor, we have access to the means, but as you also said, the lack of fear of death, complete lack. There's a degree of longing, but also a lack of fear of death, which has appeared. So it makes it easier to live.
But also, it's better for the relatives, because people like you can say, well, look, death isn't what you think it is, and why are you grieving? Because there's no need to. In fact, you've got the short end of the stick, whereas we've got the long end. We're doing okay. We're doing far better now than you were previously. So yes, that's interesting. Thank you.
Okay.
Thanks, Jonathan. Yeah. Okay, so I'd like to take at least one question from the room.
Yeah.
Just want to ask, maybe a simple question, the difference between cardiac arrest and your brain function ceasing. Isn't there a time delay after cardiac arrest that your brain activity stops?
Yeah. 10 to 20 seconds. After
But he
that.
said he was timeless, so I'm thinking, in that 10 to 20 seconds.
Now, this is one of the arguments that it could be happening in the peri-arrest environment, but it doesn't seem to be happening in the peri-arrest environment, because CNS function decreases very rapidly indeed. Generally speaking, within 15 seconds of cardiac arrest, patients, if they're running EEGs, there's still you flatline. There's no EEG activity at all. So the brain becomes isoelectric, and the duration of these experiences is significant. It's far longer than the time it's going to take between the brain to shut down. Possibly you could say there's a massive time compression, as seems to be happening here. But I think the evidence is just there's too much evidence from patients who've had NDEs of actually seeing what's going on. And by the time they initiate CPR, your brain's already flatlined. You've already got no brain, there's very little brain activity. So how are you seeing things from beyond with a brain that's not functioning, with eyes unfunctioning? But actually, no, when you become unconscious, if you faint, your vision, hearing goes first, then vision. And you've got no hearing, you've got no vision, yet you're going to be able to give us an accurate blow account of your resusc. Doesn't work that way. So yeah, it is functionally independent of brain function, which means that suggests once again that consciousness may not be intrinsically part of the brain. Yeah.
So, Philip, we're at 1:30, so what I might suggest is that we say goodbye to those who need to leave, and thank everyone for being here and opening this dialogue. I think it's something that we should and can explore further in due course. I can see some people in on the Zoom screen that have got an interest in this, and some people who do research in this field as well. So it might be something we can take up again, or have a little group that works on this at NTI. So I'll let you know of any opportunities like like that in the future. And if you do want to stay and continue to ask questions of Philip, I'm sure he'd be obliging for the next 5 to 10 minutes.
Oh, yeah, no
Yes,
problem.
thank you. Such a very kind and generous. And so thank you to all who need to leave, and thank you for coming. And the floor is open for a little bit longer.
我给他拿个那样看吧。给了给了。
Accept things. A lot of people at our age do.